Welcome back to the Deep Dive. Today we're tackling something huge, truly transformative, antibiotics, these chemical superpowers.
You really are. I mean, modern medicine pretty much hinges on them. Surgery, transplants, none of it's safe without controlling infection.
Exactly. But before we jump in, maybe we should pin down the term. Antibiotic gets used a lot.
Good point. Yeah, strictly speaking, an antibiotic targets bacteria, only bacteria.
Yeah, okay.
It's actually part of a bigger family called antimicrobials. That group also includes your antivirals, antifungals, the whole lot.
Got it. So today is all about the bacteria busters. We want to look at, well, how they work, right, without hurting us.
Precisely. And the major classes, and then the really big issue everyone's talking about, resistance.
Okay, let's start with the how. How do they kill bacteria but leave our own cells alone? That seems like magic.
It's clever chemistry. The core idea is something called selective toxicity.
Selective toxicity.
Meaning the drug has to be deadly or at least harmful to the bacteria, but essentially harmless to us, the host.
And they do that by finding differences, things bacteria have that we don't.
Exactly. They exploit unique bacterial features, things human cells just don't have or have in a very different form.
Okay, so what are these bacterial weak spots? The main targets?
Well, fundamentally, there are about 5 main ways these drugs work. 5 main mechanisms of action.
5 ways. Okay, lay them out for us.
First up, and probably the most famous target, is the bacterial cell wall.
Ah, right. Bacteria have that rigid outer layer we lack.
Correct. So drugs like penicillins, they interfere with building that wall. And if the wall isn't built right,
The whole thing just bursts.
pretty much, it ruptures and dies. We call that bactericidal bacteria killing. Very effective.
Okay, number 1, smash the wall. What's next?
Number 2, attack the protein factories. They're ribosomes.
Ribosomes make proteins, essential for everything.
Yep. So drugs like macrolides or tetracyclines, they gum up the works in the bacterial ribosome. This usually stops them from growing or multiplying.
So it doesn't kill them instantly, but stops them in their tracks.
Often, yes. That's generally called bacteriostatic. It halts growth, letting the immune system clean up.
Makes sense. Wall proteins. What's number 3?
The DNA blueprint. Stop the bacteria from copying its genetic material.
Can't replicate if you can't copy your DNA.
Exactly. So drugs like the fluoroquinolones, they interfere with key enzymes needed for DNA replication and repair.
Okay, number 4.
Blocking essential supplies. Bacteria, many of them, have to make their own folic acid. It's vital for building DNA and RNA.
But we get folic acid from our diet, right?
We do. So drugs like sulfonamides block that bacterial production pathway. Doesn't hurt us, but starves them.
Clever. And the last one, number 5,
A bit less common, but very direct, damaging the cell membrane.
punching holes in the outer skin.
Sort of, yeah. Makes everything leak out, usually instantly fatal for the bacterium. Think polymyxins.
Okay, 5 key strategies. Let's dig into the cell wall fighters first. That feels like where it all began, with penicillin.
Absolutely. Alexander Fleming, 1928. That mold juice, it changed everything, its target, building that cell wall.
How does it actually stop the wall building?
Penicillin and its relatives like the cephalosporins, the beta-lactams, they basically latch onto the bacterial enzymes that do the building.
The construction crew.
Exactly. They bind to these penicillin binding proteins, or PBPs, and just stop them from working. The wall doesn't get finished properly.
But bacteria fought back, didn't they? Resistance started early.
Oh, immediately. Which led chemists to tweak the structure, creating the cephalosporins. Still beta-lactams, still hitting the wall, but more advanced.
And they come in generations, 5 of them.
Yeah, it's like watching evolution in a drug class. The early generations, like first gen, were mostly for gram-positives.
Gram-positives, thicker walls, generally.
Right, but then you get to the third generation, like ceftriaxone, and they're powerhouses against gram-negatives, used for serious stuff, meningitis and the like.
And the 5th generation, that one's critical now, isn't it?
Hugely critical, because ceftaroline, the main 5th-gen drug, is one of the few beta-lactams that actually works against MRSA.
MRSA, methicillin-resistant Staph aureus, the hospital's superbug.
Yeah, that's the one. So having ceftaroline is vital.
Speaking of MRSA, that brings us to another big gun, vancomycin. Not a beta-lactam, right?
Correct. It's a glycopeptide. Different structure, different mechanism, but still target cell wall synthesis. It's often the go-to for serious MRSA infections, like in the bloodstream or pneumonia.
So if penicillin ties up the construction crew, the PBPs, How does Vanco stop the wall?
Vancomycin is sneaky. It doesn't bother with the enzymes. It goes for the raw materials.
The building blocks.
Exactly. It binds directly to the peptide precursors, the dial-dial units, before they even get incorporated into the wall. It basically intercepts the delivery trucks.
Okay, that's a key difference.
Yeah.
Explains why it works when beta-lactams fail. But Vanco has a reputation. Tricky to use.
Very tricky. It requires really careful monitoring. We have to measure the drug level in the blood, specifically the lowest point before the trough level.
Why the constant checking?
Because the line between effective dose and toxic dose is thin. Too much, and you risk serious nephrotoxicity, kidney damage,
Ouch.
and ototoxicity, hearing loss,
Hmm.
which can be permanent. So we aim for a specific trough range, usually 10 to 20 micrograms per milliliter, to kill the bug but spare the patient.
And then there's that side effect, red man syndrome. Sounds alarming.
It looks alarming. Flushing, rash, sometimes low blood pressure. But here's the key thing. It's not a true allergy.
Oh, what causes it then?
It's caused by infusing the drug too quickly. That triggers a massive histamine release. The solution is simple. Slow down the infusion rate.
Okay, good to know. Slow and steady with Vanco. What about oral Vanco? I hear about that for C. diff.
Right, that's a specific use.
Okay.
Because vancomycin isn't absorbed from the gut, taking it orally means it stays in the gut to treat severe Clostridium difficile colitis. Different target, same drug.
Fascinating. Okay, so we've covered the wall demolishers. Where do we go next? Inside the cell.
Let's move inside, yeah. Target number 2, the protein factories, the ribosomes. Let's talk about the ribosomal saboteurs.
Sounds ominous. We mentioned macrolides earlier. Azithromycin, clarithromycin.
Yep. These are really important, especially for respiratory bugs and particularly for what we call atypical bacteria.
Atypical.
Things like mycoplasma, chlamydia pneumonia, legionella, they don't have typical cell walls, so wall drugs don't work well, and they're tricky to grow in the lab. Macrolides are often key.
And how do they stop protein production? Which part of the ribosome?
They bind to the big subunit, the 50S ribosomal subunit, kind of block the tunnel where the growing protein chain comes out.
Interesting. And azithromycin, you mentioned it sticks around.
It really does. Its half-life is incredibly long, like 68 hours, which is great for patients, means shorter courses, maybe just once a day for a few days.
But there's always a but, isn't there? A downside to that long duration.
There can be. That persistence increases the potential for certain side effects. We worry about QT prolongation on an ECG.
Which affects heart rhythm.
Potentially, yes. Risk of arrhythmias. And also potential liver toxicity. It's a trade-off, like with many potent drugs.
Okay. What other ribosome attackers are common? Tetracyclines. Like doxycycline.
Exactly. Doxycycline is a workhorse. Tetracyclines hit the other part of the ribosome, the smaller 30S subunit.
Of different target site, same overall goal-stop protein synthesis.
Right, and they're bacteriostatic. Very broad spectrum used for acne, Lyme disease, various tick-borne fevers like Rocky Mountain spotted fever.
But they have that really famous warning associated with them, don't they, about teeth?
They absolutely do. This is crucial. Tetracyclines bind strongly to calcium if you give them during tooth development, so during pregnancy, or to kids under 8 years old.
Back incorporated into the...
Permanently, causing yellow or brown discoloration. It's a major reason to avoid them in those groups.
Wow. And that calcium binding affects taking the medicine too.
Yes. If you take tetracyclines with dairy products or antacids containing calcium, magnesium, aluminum, those divalentations bind the drug and prevent it from being absorbed properly.
So you have to time the doses carefully away from food or certain meds.
Definitely. Need to space them out.
All right, we've hit walls and protein factories. Let's move to the command center disrupting DNA.
Okay, now we're talking fluoroquinolones. Ciprofloxacin, levofloxacin are common ones.
Yeah. You hear that a lot for UTIs.
Right. They're bactericidal, very effective. They work by inhibiting enzymes essential for DNA management, DNA gyrase, and topoisomerase 5E. Basically jams the machinery for copying and organizing DNA.
Very powerful. Used for UTIs, respiratory infections, even anthrax.
Ciprofloxacin specifically, yes. It's a key drug for anthrax exposure. But these drugs come with some serious warnings now.
The black box warnings.
Exactly. We've learned over time they carry significant risks. The most prominent is tendinitis and tendon rupture.
Rupturing a tendon. Like the Achilles.
Yes, especially the Achilles. The risk is higher in older patients or people also taking steroid medications. It's a major concern.
That's serious. Any other major risks?
Unfortunately, yes. Also potential for CNS effects, dizziness, confusion, even psychiatric side effects, and peripheral neuropathy, nerve damage in the hands and feet, which can sometimes be permanent. So powerful, but definitely not first line unless really needed.
That's the current thinking, yes.
Mhm.
Use them judiciously.
Okay. What about the folic acid blockers, the sulfonamides? Bactrim.
Right. Trimethoprim sulfamethoxole, or TMP-SMX. These are synthetic, not derived from microbes. They block two sequential steps in the pathway bacteria use to make folic acid.
And since we get ours from diet, it only hurts the bacteria.
Correct. Bacteriostatic, usually. Very useful for UTIs and, importantly, often effective for community-acquired MRSA skin infections.
So an option for MRSA outside the hospital?
Yes, for certain types, like skin abscesses.
Yeah.
And it's absolutely critical as the first-line treatment and prevention for PCP, pneumocystis pneumonia, in patients with weakened immune systems, like in HIV/AIDS.
But sulfa drugs. Allergies are a big deal here,
A very big deal. They are notorious for hypersensitivity reactions. While most are mild rashes, they can rarely cause devastating conditions like Stevens-Johnson syndrome, SJS, or toxic epidermal necrolysis, TDN.
Those are the ones where the skin basically blisters and peels off. Yes, they're medical emergencies with high mortality. That potential, however rare, means we use them carefully. Also, avoided late in pregnancy due to a risk called kernicterus in the newborn.
Wow. Okay, one more group in this section. The aminoglycosides. Gentamicin.
Yes, gentamicin, tobramycin, amikacin. These also hit the ribosome, the 30S subunit like tetracyclines, but they are strongly bactericidal.
So they kill bacteria quickly.
Very effectively, especially severe gram-negative infections. Think Pseudomonas, E. coli, Klebsiella in serious settings like sepsis or hospital-acquired pneumonia, often used with a beta-lactam for a synergistic effect like in endocarditis.
Sounds powerful, but I'm sensing another butt toxicity again, like vancomycin.
Exactly like vancomycin in terms of the type of toxicity. Aminoglycosides require very close monitoring because they carry a high risk of nephrotoxicity, kidney damage, and ototoxicity, hearing and balance problems.
And that hearing loss, permanent.
It can be, yes. Both kidney damage and ototoxicity are related to the dose and how long you use the drug. So again, it's that tightrope walk, enough to kill the bug, not enough to cause lasting harm. Levels need careful watching.
Right. Seems like a recurring theme with the heavy hitters. Which brings us nicely to our last category, the reserve forces, the ones we save for the toughest battles.
Precisely. These are often our last lines of defense against multi-drug-resistant organisms. First up, the carbapenems.
Okay, what makes them special?
They are beta-lactams like penicillin, but they have the absolute broadest spectrum of activity we have. They cover almost everything, gram-positives, gram-negatives, including nasty ones of Pseudomonas and anaerobic bacteria.
So the big guns for when nothing else works.
Pretty much. Reserved for serious, complicated infections, usually in hospitals, especially when you suspect or know you're dealing with bacteria resistant to other drugs, like those producing ESBLs, extended-spectrum beta-lactamases.
Are there different kinds? I've heard of imipenem, meropenem.
Yes. Imipenem was one of the first, but it gets broken down quickly by an enzyme in the kidneys, so it has to be given with another drug, cilastatin, which protects it.
Bodyguard drug.
Basically, yeah. Meropenem is stable on its own, has a slightly lower risk of seizures compared to imipenem, and penetrates the CNS well, so it's used for things like bacterial meningitis.
Any others?
Ertapenem is interesting because it's given just once a day, which is convenient. But crucially, it doesn't cover Pseudomonas or Acinetobacter, some key hospital pathogens, so you have to know its limitations.
Okay, carbapenem's broad, powerful, reserved. What's the final reserve class?
The oxazolidinones. The main one here is lanazolid.
And what's its niche?
It's almost exclusively reserved for serious infections caused by drug-resistant gram-positive bacteria, specifically MRSA and, very importantly, VRE, vancomycin-resistant enterococci.
VRE, another major superbug threat.
A huge threat, especially in hospitals. Lanazolid offers an option when vancomycin fails or can't be used.
How does it work? Is it another protein synthesis inhibitor?
It is, but its mechanism is unique. It binds the 50S ribosome, but it acts very early, preventing the whole ribosome complex from even forming properly to start making proteins. Blocks initiation.
Unique mechanism, useful against resistance. But cautions, side effects, interactions.
Big ones. Clinically, the most critical thing to remember is that lanazolid is a weak MAOI monoamine oxidase inhibitor.
MAOI, like some old antidepressants. What's the risk?
The risk is serotonin syndrome.
Oh.
If you combine lanazolid with other drugs that boost serotonin, like common antidepressants, the SSRIs or SNRIs, it can cause fever, agitation, muscle rigidity, confusion. It can be life-threatening. Needs careful medication review.
Wow, that's a major interaction to watch for. Any other long-term issues?
Yes, particularly with longer courses, say beyond 14 days, there's a risk of myelosuppression, mainly low platelet counts, and also peripheral neuropathy, similar to the fluoroquinolones.
Okay, so linezolid, powerful against MRSAVR, unique mechanism, but watch out for serotonin syndrome and long-term nerve blood count issues.
That's the summary, yeah.
So, stepping back from all these details,
Hmm.
what's the big picture here? We've seen amazing chemical precision, drugs targeting tiny bacterial parts.
Right, vancomycin hitting specific building blocks, fluoroquinolones jamming DNA enzymes. It's incredible molecular targeting.
But that power often comes paired with significant risks, doesn't it? The toxicity tightrope with vancomycin, aminoglycosides, the tendon risk with fluoroquinolones.
Absolutely. It underscores that these aren't simple cures. They require knowledge, care, monitoring, and the biggest takeaway really has to be about stewardship.
Stewardship, meaning using them wisely.
Exactly. Every single time we use an antibiotic, especially inappropriately, like demanding one for a viral cold or flu where it does nothing.
Or stopping the course early because you feel better.
Yes, all of that drives resistance. It puts pressure on bacteria, selecting for the ones that happen to survive the drug. That's how we end up with MRSA, VRE, CRE, these multi-drug resistant nightmares. We are genuinely running out of options for some infections.
We have to protect these tools. They're a finite resource, in a way.
A very finite resource. Which leads to the really challenging question, doesn't it?
Go on.
Well, if bacteria have managed to develop resistance to basically everything we've thrown at them, from penicillin back in 1928 all the way up to our latest carbapenems and linezolid, what comes next? What truly new ways to attack bacteria? What undiscovered molecules or strategies where we need to find to make sure that, 50 years from now, we can still reliably treat something as basic as a common skin infection?